One of my favorite procedures that I've done for about 20 years now is brow lifting. Now, there's so many ways to do brow lifting. The old school kind of traditional way, which I still like to use for people with very thick skin, heavy brows. A lot of men really like if some mafia boss came to me, he would need a coronal brow lift. That means we're gonna go behind about 5-6 centimeters behind the hairline, make sure the hairline's good. We go and lift the entire brow. You also do this when you do feminization surgery and you want to shave down the supraorbital ridge and contour the bone down. We can get the corrugator muscle here, which I helped describe a long time ago through the biggest study ever done to directly measure it. Here's the article. And here's an illustration of how big that muscle that we Botox all the time looks like. We go in, we directly release the brow, all the ligaments, the retaining ligaments, lift it, custom shape it, or not even lift it. We just release it and get the forehead lines dealt with. The other one is a hairline brow, which really has low indication. It's great when you want to lower the hairline. You have to be very careful on how meticulously you make the cut and resuture, so it's not just a line or curvilinear, but you got to kind of do this squiggly, kind of Charlie Brown t-shirt thing and put that all back together. That's a hairline brow lift. It's really good for someone with a strong hairline. So I usually reserve those for women because women don't really recede too much. So you can do that one. My favorite one, which I can do in about 95% of people, the 5% fall into probably a coronal, is the endoscopic brow lift. Now, I was fortunate enough to learn this from the gurus, creators, and most popular surgeons that did this in the 90s, 93, 94 it was described. And then into the 2000s, Dr. Ghavami, who really took this another level and does migraine surgery. Now we all do migraine surgery by releasing the nerves through an endoscopic brow lift approach. And then Dr. Steve Bird, one of my mentors in Dallas. So this brow lift approach, you can release the ligaments. You can see here right now, I'm showing you the endoscopic view on my plasma screen or my TV screen that shows you the muscles and the nerves. You release those, you release the ligaments, you remove muscle if necessary, so you may never need to really get that much Botox ever again in your life. You get a really custom tailoring. I've had patients come in who one brow's here, one brow's here, and we want to even them out so you can do a nice release and shaping of the brow. You can really customize it. I also love to go through that approach down to here and join my other incision down here and in front of the ear and hairline around the sideburn for a high smash, deep plane, extensive facelift. The high smash facelift is my favorite technique, recruiting the cheek. Often when you go so vertical to get that beautiful verticalization and narrowing you're seeing in all the celebrities right now, you have to go kind of vertical oblique in that vector going this direction. And that allows a lot of excess here, which means you need to do a brow lift to recruit that and make it drape, the tissue to drape nicely. Now, many times people come in, they think they need their eyelids done, where what they really need is they need the heaviness of the brow taken up. So a lot of times you can do an endoscopic brow lift and you don't need any eyelid surgery. But in about 50-60% of cases, you need both. You lift the brow and then you have a less requirement for removing skin. So the upper blepharoplasty incision, I do a zipper approach where I do a clean closure of the eyelid muscle and zipper up there. And you can go in and get the ROOF, retroorbicularis oculi fat. And in the lower lid, you get the SOOF, the suborbicularis oculi fat. They're two very analogous, similar fat pads. This fat pad here, I pluck it out. You don't want to remove too much, and sometimes you don't want to remove any of it. The worst thing you can do is remove too much fat deep in the eyelid and make this sulcus deep. People actually look older, so sometimes I have to actually transfer fat up here when I'm doing a brow lift or facelift. So this periorbital anatomy, the upper eyelid and brow, are intimately related and connected, so it's up to your surgeon. And a lot of times I like to do something up here to make that crisp. Lower eyelid is a whole nother can of worms. We'll do another video about that. I'll show you the anatomy. I actually described the orbicularis retaining ligament here a long time ago in the anatomy, along with other anatomists like Mendelssohn and Kikuwa and Joel Pessa and others who really concentrate on this orbitomalar orbital retaining ligament that causes this. The reason when you get a black eye that it looks so raccoonish is because that bruising doesn't go past this ligament. You release the ligament and you can do some blending of the lid cheek junction, get some eyelid muscle across and under the muscle and blend this, and then do some fat grafting and do rejuvenation of the lower eyelid. We'll talk about that in depth later. So brow lifting, top brow lift procedure I like to do is endoscopic, small incisions, works with any hairline. approach the brows, release. You can go all the way to the mid-face and lift the mid-face a little bit in someone younger, or combine it with a high smash or other facelift that really goes vertical, so you end up needing to do the brow lift together. You get results like these patients here. These both have had a high smash and an endoscopic brow lift, obviously with some other things to enhance fat grafting, etc. That is the beauty of the era we live in right now. If your surgeon is adept at this anatomy, is comfortable and can do the level and extensive depth that you require, especially the most advanced one, the high smash, then all these different techniques, the 4 facelift techniques, can be done combined with brow lifting. That's how you get a natural, long-lasting, effective, but transformative result.